The Mohandas Memorial Oration next to be delivered by Dr.Bobbie Abraham. May I invite onto the dais the Chairman ASI Kerala Chapter, Dr. M.P. Srijayan, the National Office Bearers, Dr. Santosh John Abraham, Dr. Rajan, Dr. Muhammad Ismail, Dr. C.J. Varghese, Dr. R.C. Srikumar, Secretary ASI Kerala Chapter, Dr. Madhu Murali. The Mohandas Memorial Oration, and hand over the proceedings to the Chairman now.
Rajan sir.
Once again, the dignitaries on the dais, Chairman ASI Kerala Chapter, Dr. M.P. Srijayan, National Office Bearers, Dr. Santosh John Abraham, Dr. Rajan, Dr. Muhammad Ismail, Dr. C.J. Varghese, Dr. R.C. Srikumar, and Secretary ASI Kerala Chapter, Dr. Madhu Murali.
Srikumar. We'll start the proceedings. Dr. N. Mohandas was born to an illustrious family of writers in a village called Punnenkulam, 6 kilometers from Guruvayur. His father was late V.M. Nair, managing director and editor of Madhubhumi, and mother, the famous poetess Nalapad Balamaniyamma. He had his early education in the village school and passed SSLC from Kunnankulam High School, standing first in the examination. He took his intermediate from St. Xavier's, Calcutta, and MBBS from Madras Medical College. He took his fellowship from the Royal College of Surgeons of Edinburgh, returned to India and joined the Kerala Health Service as surgeon, General Hospital, Calicut. Few years later, he left it and started his own practice, and between 1975 and 77, he worked as professor of orthopedic surgery at Iran. He was a consultant orthopedic surgeon in PVS Hospital, Calicut, till his death. The different positions held are: he was a Fellow of the British Orthopedic Association, Fellow of the International College of Surgeons, Fellow of the Academy of Medical Specialists, Member, Governing Council, Association of Surgeons of India, an Executive Committee member, Indian Orthopedic Association. Apart from that, he was the JC President, JC Senator, and President Rotary Club of Calicut East. Has 4 children, and the elder one is Dr. Ajay Kumar, neurosurgeon at Vaikam, Kerala, and Madhavachandran, Mohandas, and Balamni. For the year 2024, Association of Surgeons of India Kerala Chapter has decided to bestow the Dr. N. Mohandas Oration to Dr. Bobbie Abraham, and I invite Dr. Bobbie to the dais. Madhu Murali, please. I invite Dr. Madhu Murali to read the citation.
Good afternoon all. Dr. Bobbie Abraham, born in 1954, did undergraduation and postgraduate studies at the prestigious CMC Vellore. Dr. Bobbie belongs to the era of true clinical general surgeons capable of handling most of the surgical issues. However, his keen interest lies in the surgery of parotid, thyroid, parathyroid, breast, and hernia. After training from CMC Vellore, Dr. Bobbie joined the famous Memorial Hospital at Fatehgarh by the American Presbyterian Hospital Group. He spent a few years in Saudi Arabia as a consultant surgeon. On returning to India, he joined the Tiruvalla Medical Mission Hospital. Since 1998, Dr. Bobbie has been working at Caritas Hospital and has been hugely responsible in developing the Department of General Surgery to the present level. The department today is recognized as a DNB training program in general surgery. Dr. Bobbie, with the MBA in Hospital Management, was the right choice for the post of the Medical Director of Caritas Hospital and Institute of Health Sciences, Kottayam. His key interest in that role includes upgrading the availability and sustainability of medical sciences, improving the quality and safety in medical care, training of doctors and nurses, building and empowering hospital departments, fostering team working among healthcare workers. His vision and leadership has given a facelift to Caritas Hospital at Kottayam. He is active as a public speaker and has been an invited speaker at the Indian Express Health Conclave. Members of the Associate Surgeons of India, Kerala chapter is honored to bestow the prestigious Dr. N. Mohandas Memorial Oration for the year 2024 to Dr. Bobbie Abraham.
I invite Dr. Bobbie to deliver the oration. Thank you.
Thank you very much. I don't know what I can do with this oration to prevent hypoglycemia, but I'll try my best. As surgeons, we're not used to having a lunch before 2 o'clock. Thank you very much for inviting me. I'm indebted to the Association of Surgeons of Kerala, more especially to the Surgical Club of Kottayam, various members including Dr. Binny, Dr. Sri Jain, Dr. Madhu, Dr. Santosh, my own department, I think Dr. Jibu is here. I bring greetings from Caritas Hospital, Kottayam. I'm also indebted to my wife for driving me here all the way from Kottayam and hopefully back after these sessions. I read with interest and delight when the theme for this conference was surgical alchemy, the binding. And very strong words have been used, transforming challenges into triumphs. Transforming challenges into triumphs. How wonderful. Today, I hope to talk about safety in surgery. We have all heard, and we have a lot of very good surgeons here. But I also realized that in this conference, a lot has been said about the non-technical, which matters, and imbibing the safety culture, the checklist culture. I've headed this slide with something very strong, possibly something terrible. It says, embrace and endorse patient safety, otherwise perish. I don't wish for that to happen to any of us or to our patients. Very often we see a blame and shame culture. We used to talk about human beings and their error prone as being error prone. But now there has been a whole science behind it. It's called human factors, the science of human factors. We have recognized that humans have abilities, separate characteristics, and limitations also. And the environment that they work in, the design of equipment that they are forced to use or use, and the environments that they function in, and the jobs that are expected out of them, the outcomes, all play a role in preventing or providing for errors to happen. Going a little further, errors are often attributed to individuals. Most, however, very important for us all to know that they are due to not human errors alone, but due to defective systems that allow errors to go unnoticed. Our hospitals, all hospitals, whether in India or abroad, provide multiple opportunities for suboptimal communication, discordant motivations, errors due to cognitive biases, poor interpersonal skills, and substandard environmental factors. These are all independent of poor technical skills, for which we have heard a lot about the importance of mentoring. I came from CMC Vellore about 30 years back, not born in Kerala, brought up outside, and I was searching for a mentor, and my mentor was Professor Matthew Varghese sir. I was able to work with him for 3 years at Tiruvalla Medical Mission. He taught my wife, so it was easy for me to break the ice. He's still my mentor, and it is to him in Kerala, among all the others here, that I look up to. I was also fortunate that I could help him survive a GI bleed due to a aortoduodenal fistula. He didn't want surgery. We offered him interventional radiology, put a stent across the aorta. He's still living. I'm thankful to God that we could, at Caritas, help to save his life. Now, human factors can be good or bad. Today, I'd like us to think about the dirty dozen. When I look at myself and the places that I work in, and probably each of you can think in our minds, what are the dirty dozen? Daily pressures, the lack of communication, complacency, lack of knowledge, distractions, lack of teamwork, fatigue is of various types, lack of resources. We had a surgeon talking from the government sector. Pressure, various types, lack of assertiveness, stress of various types, lack of awareness, and the various norms that are enforced on us. These are the dirty dozens. There are very many more. Most of us are aware of the Swiss cheese model. I use this at Caritas to do kappa. Whenever there has been a problem, I find this easy. I'm not a statistician, but I use this to find out and teach and learn how to arrive at a solution for the problem, if possible, or to prevent such a happening in future. Human factorization is the thing that we learned from the industry. Human factors were first noticed in the aviation industry, in the armed forces, in the industry in general, to prevent errors. And these have been introduced widely in surgery by surgeons and the WHO. Dr. Atul Gawande's name was mentioned earlier. He is the one, probably among many others, who have contributed to saving many lives. Human factors are major contributors to errors in healthcare, which when combined with defective systems and organizational structures can cost lives. The leaders among us, the seniors among us, the less senior among us, those with lot of future, we must think not about a human being, but about the team and the environment that we work in. This should be our future. If we work together, if we think together, if we plan together, then there's a future for surgery. There's a future for the patient. There's a future for safety all around. Why should we have a safety culture? Why should we optimize it? It's a very abstract concept, unless type of thought, but it's essential. Why and how? Dr. Santosh had talked about balancing our work with other life issues. Very important, all this counts. Errors in healthcare towards patient safety are majorly human factors. Yesterday, we heard Dr. Rajan talk about humility. There has to be humility in all of us. At Vellore, I was mentored by Dr. A.S. Fenn, Dr. Joe Devdatta, and Dr. Prakash Kanduri. Professor Kanduri once told me, we surgeons are like the soldiers posted at the Pakistan borders. The moment pride gets into us and we raise our heads, we'll get shot. We have to learn the skill of being humble. Learn that humbleness and humility are essential as human beings and especially for surgeons. Improved surgical safety through teamwork-based approaches which include simulation, standardization and training. Assess safety culture. Identify areas for improvement. We open our eyes, we open our ears, we open our minds and look around. You will find areas where we can, in our own small, big ways, improve teamwork, improve process flow. It will make a big difference. It will decrease wastage and decrease error. Measure with surveys. The easiest that I find are Likert scale, easily, two minuses and two pluses. Raise staff awareness. Unless they are aware and understand, they will not be part of our team. Evaluate interventions. Are they optimized? Can they be optimized? Can they be made better? And track changes. Identify, like in a SWOT analysis, strengths and weaknesses. What does it involve? It involves all of us. Team training, patients' safety team creation. Among a group of 10 of us, probably 2 or 3 will volunteer initially. About 50% or more will sit on the fence and probably join us. Some of the seniors and juniors among us may take a longer time to join, but when they see the good outcomes, the decrease in harm, then definitely they'll adopt and adapt. And this will improve safety culture. Safety culture is the hero as far as preventing patient harm is concerned. Not only patient harm to us. When we go to the court, we must remember that the option is adopt a safety culture, adopt checklists. Positive safety culture is a safety umbrella that hovers over us, over our team, over the patient and bystanders, and creates a teamwork climate, creates a safety climate, endorses good working conditions, recognizes stress not only in ourselves but amongst our co-workers, and makes the management change its perspective. Communication is the cornerstone. We have to learn how to communicate, not through our mobiles, but openly, face-to-face, multidisciplinary, even intradisciplinary. We need to communicate. We are losing that because of all the electronic gadgets that surround us. Checklists save lives. Checklists are actually, and participating in checklists is like a sacred prayer that we pray before we embark on our journey. 3 or 4 days back, a colonel retired from the army who had been on various missions was to undergo a CABG. Active all his life, probably He thought nothing would happen to him. He came with triple blocks. He came with a bad heart. Angioplasty was not the option. CABG was planned. As he lay on the table, he called the anesthesiologist and the surgeon. Could we participate in a prayer? He prayed for the surgical team, he prayed for the anesthesia team, and last he prayed for his family and then his wife. It transformed. This is what really happened in Caritas 3 or 4 days back. I was part of that, so I knew. And the anesthetist came and told me that made a big change to them. I would request and pray to you that we consider checklists in our everyday lives, not only in the surgical theater, but in everything that we do, especially as a team, because it is what saves lives. It is what prevents errors. Don't take it lightly. Checklists were developed in the aviation industry probably after that horrific crash that I showed. There's a need for structured, collaborative, sustainable implementation strategies. There's a need for establishing multidisciplinary teams to talk to each other, to discuss and implement the checklists. It involves all of us surgeon leaders, old or young. It involves pilot testing the checklist. Do it on a small group and realize how important it is, how useful it is, how safe it is, and incorporating feedback from team members. The medical director alone should not be speaking. Get the junior most in the team, the newest in the team, to voice his or her concerns and address barriers to implementation. When we incorporate feedback from team members, we can realize what the barriers are and implement them, change our strategy, and offering coaching, mentoring, continuous feedback to team members who use the checklist. The WHO Health Organization brought in this surgical safety checklist. It has been used all over the world, even in underdeveloped countries. In Africa, it has made safe surgical and all procedures safer, much safer, both for the patient, the relatives, and the whole surgical team and the hospital. What it means is thoroughness, definite, be part of it. Don't be a person who at the end of the surgery just without participation actively in it. If the surgeon just signs a checklist at the end of the surgery, the value of the checklist is lost. How do we endorse implementation of the checklist, being a part of it? Each one of us. Take the checklist to our endoscopy theaters, to the cath labs, to the dental theater, to when you do a central line, we should put a central line on the right patient. Check whether this patient has allergies. All this is part of the checklist manifesto. It's a prayer to keep all of us safe. And it means thorough checking of all checklist items by every member of the team. Thorough communication of all checklist information to all the team members. It stresses on all and each one of us. Thorough leadership. There's a leadership to be found in each one of us. Thorough education by giving information. How do we educate? By giving information to one another. And organization by improving workflow, by structured information exchange. It has to be structured. We have to be focused. And it has been proved all over the world where when the checklist has been implemented, reduction of perioperative morbidity and mortality happens magically, happens as if an answer to a prayer. Surgery means team working. OTs are high risk, high stress, time sensitive This is a place where there's a cacophony of sounds, a lot of wires going around, lot of machinery, lot of people with different attitudes, different environments at home, different educations, who spend some time together to try and do something for the patient. This is the risk that we subject ourselves and to our patients to. Non-technical skills and situational skills matter. We need to be, especially as surgeons, along with others who are part of a team, be able to stand up even when, in my Malayalam, we are thrown into the challa. We should be able to stand up upright. Crew resource management, well endorsed in the aviation industry, has to be endorsed by all of us. Teamwork interventions like training, tools to facilitate teamwork, organizational rework to stimulate team process and functioning are the need of the hour. It has to be part of our everyday lives. All of us as surgeons are familiar with the checklist. Read it, think about it, dream about it. It will help you not only during surgery, it will help you in all aspects of your private lives also. Check, communication, discuss. This is very important. I'll just go through it. It has 3 parts. We can modify it. In fact, WHO has said, modify it as per your conditions. But keep us all safe. How do we do? Simple. Sign in before induction of anesthesia. We will prevent, yesterday also, how horrible it is to operate on the wrong patient. How horrible if you operate on the right instead of the left, and you operate on the wrong part of the body and the consent is not in place. I was reading somewhere that the incidence of litigations in India in the last 1 year has increased 400%. I'm sure a lot of it in Kerala, and probably it's more than 400% in Kerala. As a medical director, I deal with very many litigations. As a medical lawyer, I have to tackle circumstances where some of these things are missing. It makes it very difficult. The timeout before we start the surgery, it is a talk where we introduce each other, not the surgeon alone, but the anesthesiologists, the technicians, the nurses, and the people, the scrub nurses, the floor nurses, each one of us. They'll have some story to tell which will save us. Some story to tell that this surgery has these problems, we anticipate this blood loss, these are the critical areas, these are important. And unless we do that, unless we run a running commentary, especially while operating also, I'll tell the anesthetist, I am at this such and such structure, I will need this time, I need a little time, I need your help, I need probably more relaxation. I'll be keeping on talking. This is very important. A running commentary need not be loud, but we should be perceived by everyone in the theatre is very useful to us. Signing out again is a transition of care. All transitions of care are associated with risks to all of us. I say not just to the patient, but to all of us. What happens to the patient happens to us. And has the name of the procedure been recorded? We may not remember intricate details 1 week after that, or 1 month later, or when we get a notice from the court. Have the counts been recorded? Once upon a time, I was operating on a patient with a papillary carcinoma thyroid, short neck, young patient, multiple nodes on both sides, so bilateral lymph node dissection had to be done, central lymph node dissection had to be done. Evening, I usually join in for counting the gauze pieces and get it counted twice in front of me by 2 staff. That day I didn't, because I came in from another theatre. I was told the counts are correct. I asked, participated in the checklist, but I didn't participate in the count itself. While closing, they could find only 19. Usually there are 20. It's the neck. Looked all around, removed all the drapes, had the neck x-rayed, couldn't find it. Finally, the nurse told me, you have to write in the count book that one is missing. I wrote it. And till today, 5 years have gone by or more, I asked that patient, has anything come out? I still will continue to ask that. But from then, I stopped. I stopped using gauze pieces in abdominal surgery, only mops. I stand there so that that should not happen to me. I'll tell you another story. As medical directors, we face it. As administrators, one day, the chief pathologist came to me, huge retroperitoneal sarcoma, beautifully done surgery, but nothing left of it. The formalin wasn't there. They have forgotten to add the formalin. Medical directors devise ways of getting out of it. And the patient went home. Well, this was 10 years back. Still alive, doing well, no recurrences. Another time, especially, even get the specimen put into, labeled, put into the container and formalin put or some other, if it's saline, in front of your eyes. And see that it is sent. Otherwise, we can't blame anybody else. So, this is the sign out which says, shouldn't we participate in it wholeheartedly? Otherwise, we can land up in a problem. And before we shift out, we have to discuss what is going to happen to the patient. What are our reconciliation of everything that has happened and what is to happen again. Teamwork based surgical training is very important. Why? Because 50% of errors in the hospital occur in the OTs and procedure rooms, and 50% are related to an operation. OTs, cath labs, endoscopy suits, among all the others, any part of the hospital errors can occur, are high risk, time sensitive environments. Team members, as I said, are diverse in their technical and non-technical expertise. Hospital and surgical teamwork training borrows principles from aviation crew research management. These are well-trusted training tools, so don't throw them away, endorse them, embrace them. And teamwork training for OT emphasizes non-technical skills of the team rather than the technical skills to perform the surgery. We must become experts at crew resource management, which should be a part of organizational safety culture and be approached as high priority management. Crew resource management is about the human factors as sources of error, but also about humans as the best resource to avoid human errors and incidents again. This will involve briefing, error management, workload management, closed loop communication, not our own, but our whole team, each member, stress management communication. PGs everywhere, also faculty, in all big hospitals we see have a lot of stress. You know that, I also know that. We have to deal with it. Situational awareness, the surgeon, the anesthetist all round should know not only what is happening to us or to the patient alone, but what is happening around in the environment so that we can adjust, take corrective action. Leadership is something that is essential in each one of us. Bring out that characteristic in you. Bring it out, practice it. Don't be ashamed of it. And team working has to be learned. The ability to make decisions and not pass it on, or where to escalate, is very important. Where to escalate, very, very important. And this is a tool that I use for teachable, for learnable skills which improve outcomes. Remember it all our lives. Communication skills, team leadership skills, situational assessment skills, and mutual support. We watch each other's back as soldiers do on the frontier. And patient safety and all-round safety depends on organizational culture. The management has to realize that this is important, teamwork. They cannot pitch one surgeon against another surgeon. Definitely not. We cannot have private revenges. No, not in surgery. If they run around away with others, people's wives, definitely yes, but not in the hospital. Hospital work is very professional and leadership is very important. But what underscores is communication. Learn how to communicate. And Team Steps is an evidence-based framework to optimize teamwork and performance across the whole healthcare delivery system. It means a shared mental model as far as knowledge is concerned. You have to have a transformed attitude, mutual trust, believe, and have a team orientation that is forward. This is our focus. Performance involves adaptability, accuracy, productivity, efficiency, safety, and high reliability. We will discover it as we go along in our journey towards developing a safety climate and sustainability. It should not get over with one operation. It has to be part of our lives. How can we assess observational teamwork? Very important. We often do observational teamwork studies in an assessment in Caritas. Look at the non-technical skills and discuss with surgeons what's happening, how he behaves, how she behaves. Surgeons' leadership inventory, anesthetist non-technical skills, and the non-technical skills of scrub nurses. These are very important because they form part of the team. Develop teams in your wards, and I'm saying hand-holding is very important. Teamwork hand-holding saves lives, protects us from harm and lot of problems. Care pathways. NABA says develop pathways. We leave it till the inspection. No. What do pathways do? They standardize and simplify. Checklists, embrace it. Make it the prayer of our lives. The universal protocol, timeout, checklists, wrong patient, wrong procedure, wrong site are avoided. Start enhanced recovery programs, ERPs as they're called. If we maintain ourselves and our teams in homeostasis, and our patients and the bystanders in the perioperative period in homeostasis, the outcomes are much better. It is proved all over the world. Studies are there. Keep the patient and the bystander and the team undisturbed. The outcomes will be better. The EMR, we are all against EMRs, but develop EMRs. Caritas, we have started developing EMRs developed by surgeons for surgeons. Checklist implementation and communication and teamwork errors will decrease. Pathways are easily taught, but there's the bugbear, resistance to change. Are we the resistance to change? Is the management the resistant to change? Just think back. We are part of the management. We are part also of the patient care scenario. Be willing to change. Improve perioperative rescue. 500,000, 2,000 bed hospitals have probably the same number of complications, but different outcomes as far as patient morbidity and mortality are concerned. Why? Because there are differences in failure to rescue. Why? Because unless we develop strategies to improve communication and collaboration, expected recovery of surgery programs, we communicate this. Interdisciplinary meetings, medical boards and peer reviews, enhanced mortality and morbidity sessions, not the monthly meetings, monthly M&M meetings, but enhanced. When we see something going wrong, we do it in Caritas, Rescue Improvement Conference. Here is when I say it should not be blame and shame, because then it will not work. Safety attitudes, team behaviors, staffing, technology, and fast focus teaching. Teach our juniors and PGs what to look for, what is abnormal, so that they can pick up. If you pick up early, escalate it, work on it together, then the patient will survive transfer safely, transitions of care, intra-hospital, inter-hospitals, patients are vulnerable, we are vulnerable, and communication and care disruptions occur. Transfer of surgical patients is different from medical patients. Medical patients, probably you are used to MIs and also probably strokes. Very simple compared to transfer of polytrauma patients. Patient and bystander concerns and our concerns probably are overlooked. Coordinated transfers, create standardized guidelines and regionalization, address complexities of inter-hospital transfer, and up-to-date focused communication. There is increased mortality and morbidity on weekends. Doctors who are on weekend duty should not be called for doing routine things which could have been done earlier. Finish what you have to do before we hand over. Regular work has to be finished before the weekend. Focus briefing for patients and handovers. Transfer patient protocols to be more diligent, and night rounds. Night rounds in private hospitals are necessary. I know in medical colleges they are there, in private hospitals are necessary. A snapshot of what we do in Caritas. We are developing the OTMS. We have sessions which are based on clinical safety, safe surgery checklist implementation strategies, ICU safety throughput and risk scoring. Dynamic surgical desk, ERAS, is being implemented at least on a pilot study, and interdisciplinary meetings and medical boards, very important, sometimes only area where we communicate. Augmented M&M, augmented medical reconciliation, PA, CPs, I will add to that, doctors also work in tandem, doctor-owned EMR, CMEs, and live CAPA. We can't leave the nurses behind. We take a lot of care. In fact, as Dr. Shankar, the principal of Medical College, said, nurses are our most valued commodity and they're all disappearing. So we have to preserve, train our nurses, and probably look at other options also. This is something that was made in Caritas by the nurses to identify and implement management of bed sore or pressure injuries. My last slide is said that success, I'm quoting, success has 1,000 fathers and failure is an orphan. I think we should reverse it. Our failure has multiple parents. It's usually an error chain that leads to really bad outcomes. Becoming familiar or facile with human factors, pathway processes, risk mitigation, as well as concepts of understanding and improving teamwork, analyzing data, and creating a culture that values safety is critical to creating an environment that will minimize unnecessary bad outcomes. Thank you. The patient, our team members, our guest, Atiti Devo Bhava. Thank you. Thank you. I hope this taken some part of the hypoglycemia away. Thank you.